All right. So in the interest of time, I want to go ahead and get started. Thank you everyone for joining. And the door is open. We're going to keep things rolling for everyone. All right. Hi, my name is Dr. Sanjeev Sriram. I'm a PNHP board member at large and excited to be hosting this evening's webinar on the impacts of the Medicaid unwinding on child health. And thank you so much for joining us. We are Physicians for a National Health Program, the leading organization of over 20,000 physicians advocating for single payer and improved Medicare for all. For 35 years and counting, we have fought to make healthcare a true human right for every single person in this country, regardless of what they earn, where they live, or what they look like. And with that core mission, some of you may be wondering, why are we raising the alarm about Medicaid's so-called unwinding? As many of you know, 3 years ago, policies such as continuous enrollment were passed to keep people enrolled in Medicaid during the worst of the pandemic. Those policies ended March 31st. And since then, states are unwinding continuous enrollment and scrutinizing the eligibility of almost everyone in Medicaid. Thanks to our 50 states and the 50 shades of Medicaid that are out there, different states have been going through different processes of doing redetermination and unwinding. But according to the Kaiser Family Foundation, over 1.3 million people as of yesterday have been kicked out of Medicaid in 22 states for which there's data. 71% of those people were kicked out for procedural reasons. And procedural reasons is a very large umbrella term. It can mean any number of bureaucratic excuses for people being removed from the program. And over the next several months, there are some estimates that at least 20 million people could lose Medicaid coverage because of this redetermination process. And of that, a third, 7.2 million people are children, which brings us together as pediatricians to a crisis that requires us to raise our voices and our values, that no one should be losing their human right to healthcare because of minor changes in family income or moving across a county line or incomplete paperwork. So tonight we have a fantastic panel of physician experts and activists, and we are excited to share their insights and ignite your actions. And with that, I want to welcome all of my pediatrician colleagues joining us this evening. Please introduce yourselves if you have not already. In the Zoom chat, include your name, what state you live in, and tell us about how the lifting of the pandemic emergency policies has affected you and your patients. Just a couple of one-liners on what's been going on in your local community. And I want to introduce our panelists very, very briefly. We're going to be including their bios in the chat. And hopefully in the emails about this webinar, you got to learn more about them. But our panelists this evening are Dr. Rhea Boyd, who is Director of Equity and Justice for the California Children's Trust. We have Dr. Jane Oski, Director of Tuba City Regional Healthcare Corporation's Adolescent Health Program. We've got Dr. Marian Earls, a developmental and behavioral pediatrician and medical director of Guilford Child Health. And Dr. Phil Verhoef, our pediatric and adult intensivist and clinical associate professor of medicine at the John A. Burns School of Medicine at the University of Hawaii, Manoa, and president of PNHP. Excited to have this illustrious panel, and all of their brief bios are being added to the chat. So please feel free to learn more about this fantastic panel. All right, so in the interest of time, I'm going to go ahead and jump right into our first segment with Dr. Earls and Dr. Boyd. And yeah, there you are. Okay, so and for this first segment, what we really wanted to do was talk about the experience of COVID, the harms and crisis that have been happening with the pandemic, with the lifting of these emergency protocols and the unwinding of Medicaid and how that's been impacting children. So many of you know, COVID-19 has had direct and indirect devastation on our patients and families. And what many of us might not know or fully appreciate is that both before and during the pandemic, Medicaid has been doing so much heavy lifting for mental health in our country. So I wanted to start with Dr. Earls, to give us an overview of what children and adolescents have endured in the past few years, and how did the emergency policies passed during the earlier part of the pandemic, how did those policies help pediatricians and mental health providers caring for our patients?
Yeah, so, you would have to be living under a rock to not hear about the mental health crisis that has been plaguing us, particularly during COVID. I will say that some of the trends in children's and adolescent mental health was really happening even before COVID. But during COVID, the social isolation of kids, the increase in suicidality in female adolescents, in kids who are LGBTQ, all of that really increased during the COVID crisis. You had families that lost jobs, they lost childcare. So the impact on kids' mental health was pretty significant. So my pediatric colleagues, and I'm sure Dr. Boyd would acknowledge this, are just seeing high levels of anxiety, high levels of kids having difficulty even being back in school at this point. So there was a huge impact, and it was a disproportionate impact on kids in populations of folks of color. And so you can't be in pediatric practice without knowing about that impact. I think the fact that Medicaid was available for kids who had Medicaid, there was a lot of work around guidance to state Medicaid programs to enhance mental health services and cover mental health services, even for the youngest kids. So it's really distressing around the possible numbers of kids who are going to lose their Medicaid coverage, for sure.
Yeah, I mean, it's just it's really devastating, how much the pandemic has exacerbated what's been going on for so long. And that kind of brings me to my next question for Dr. Boyd. And actually, you know what, Dr. Boyd, just before I give you the question, I just need to let the audience know we do have the chat function on. So if there are any, we'll try to do a little bit of Q&A in this segment. I just wanted to open that option up to our audience if there's in this conversation, if it sparks a question that people really want to have asked. I'll do my best to get to those in this segment. But Dr. Boyd, my question for you is a bit kind of like it's a what came first, the chicken or the egg type question, because for me, what I think, and what I think many pediatricians have seen is that a lot of our patient struggles with mental health and their physical health, as much as it was due to the pandemic, there have been these larger systemic problems that have grown over time, and that the pandemic kind of came along and it just either unearthed what was already problematic, or it just kind of really kind of turned the knife in. And so I'm kind of wondering, how does Medicaid unwinding worsen those problems, and what have we been neglecting for so long, and what are we making worse by doing this Medicaid unwinding?
That's an important question, Sanjeev. Also, thank you for even having me on this panel, and hi to everybody at home listening. I think to answer that, we first have to think about how large Medicaid is and how many people that we're talking about, right? So Medicaid as a program covers approximately 1 in 5 Americans. 1 out of every 5 of us get our healthcare because the government supports us doing that through Medicaid. And then if you think specifically about kids, Medicaid covers over 40% of all births, over 40% of all children, an incredible sizable amount of children and births are covered by Medicaid. And then it specifically covers kids who have special healthcare needs, children with disabilities, children who are in foster care, populations that we know are made vulnerable for a number of other reasons. And then as Dr. Earls shared, it disproportionately covers kids of color. So in my home state of California, our state that is majority children of color, majority Latinx children, Medicaid covers Medicaid enrollees are over 80% children of color. So this is a government program that serves a sizable number of all Americans, but particularly Americans that have been made vulnerable by, as you've referred to, historical forms of inequality that continue to persist today. People who continue to be made vulnerable because of unequal investments in their communities and the active predatory threats of racism and inequality and disinvestment and violence that has shaped people's lives. So when we think about the impact of what's happening with this unwinding of Medicaid, or this kind of redetermination of who's eligible as we come out of the public health emergency, what that really means is the government is going to take back, as you said, this program that everybody deserves. Healthcare is a human right, and we are now going to take it back from the most vulnerable among us, children, birthing persons, children with disabilities, children who are in foster care. And of the estimated 5 million kids who are going to lose Medicaid in this unwinding process, as you noted, the majority of those kids, I think the AAP estimates 3.8 million of them, are going to lose it because of a paperwork problem, because they didn't have updated contact information, because they missed a notice that might have come in the mail, right? Which is inexcusable. It's unthinkable that we are going to keep kids from these services because of something so banal. And so I think we're having this conversation today to talk about what that means to kids. And we know that when kids don't have health insurance, they don't get healthcare, they don't get preventative medicine, they don't get screened on time, they don't get vaccinations proportionately. And coming out of the pandemic, things like preventative medicine, vaccinations, and mental health screenings are really critical to kids' health and well-being.
Yeah, and one of the things about the unwinding that I really want people to take away from this webinar is that we've been talking national numbers because this is obviously a national broadcast, and we're reaching a very wide audience, but where you live is going to have a very different and local story. And because both of you are from different regions of the country, that I wanted to kind of get both of your takes on that, because this isn't really all that much of a red state versus blue state narrative. And so, but I do want pediatricians to get an understanding of just how local this trouble is. So Dr. Earls, if you could kind of describe what you expect to see in your state as this unwinding goes on, and then maybe we can contrast that with what Dr. Boyd is going to be seeing in California.
Yeah, it'd be interesting to hear from Dr. Boyd what her perspective is. I think the American Academy of Pediatrics has made a huge effort with their membership to be using posters and information to let families know, to update their information, et cetera, to make sure that they don't miss a letter about re-enrollment and so on. And I do know that in my own state, our AAP chapter has done a lot of that work. And so, combine that with having multiple managed care plans and making sure people are getting re-enrolled with that, and whether or not they're getting notifications appropriately. It's a significant issue. And we're relying heavily on the pediatricians to really oversee that process and help at the level of their practice. I think that that's going to be where we have the most success in being able to do this. So I'm interested in Dr. Boyd on whether you think that's much different even for where you are. I think engaging the best place we're going to engage families is in our practices to make sure that we're certain that our families are getting re-enrolled and don't lose their coverage.
Yeah, the only thing that I'd add that maybe is specific to California is we just actually went through over the last couple of years. The process started just before the pandemic, and then the pandemic kind of prolonged it, but our Medicaid waiver renewal process. So we just went through a very intense process of kind of negotiating what Medicaid covers, who's enrolled, and what we could do specifically around children's behavioral health. So kids who have mental health needs and other developmental and special health needs. And in that process, we were wanting more kids to benefit from the services that Medicaid provides, because already in California, Medicaid really is the financial backbone for most child health and social services. So Medicaid funding supports school-based health centers, which is where a number of our adolescents receive all of their primary care. Medicaid supports the healthcare services for kids in juvenile justice. It supports, as I mentioned, kids who are in the child welfare system or kids who are in foster care. So it supports so many, the early childhood program, we have richly invested in Medicaid, and we just went through a process to make sure that when kids are enrolled in Medicaid, they have a new suite of services available, because our state just came also out of a economic surplus. So our Governor Newsom just announced, last year that we're going to put $4 billion into mental health care for kids in our state, most of which is flowing through Medicaid. So to think that we're now going to disenroll, hundreds of thousands up to 1 million kids from our programs that are now made more robust so that we can respond to this crisis that we have on our hands it's really devastating, because at least here in California, we've really made a lot of efforts to make sure kids can get what they need through our Medicaid program.
Yeah. I have a question from the audience that is specifically about mental health, and it's how does Medicaid unwinding affect the availability of mental health services for children, which were already, fairly inadequate before the unwinding? What can we anticipate to be, the detrimental about these mental health services being taken away?
You're asking me, I assume.
Yeah.
Yes. In August of 2022, the Centers for Medicaid and Medicare Services actually sent recommendations to Medicaid directors in the states on ways that they could enhance mental health services for kids under Medicaid. That included things like allowing for non-specific diagnosis codes so that kids could get services with that. It also had recommendations around Medicaid parity with Medicare, so that you can have a mental health workforce that actually is incentivized, and you have adequate network. We were struggling with that already in many states to move that forward and actually increase the accessibility. There were recommendations in that around integration of mental health professionals in primary care as part of the medical home team. So while you have that on the one hand, then you have this unwinding, so that we've always had the workforce issue, no matter whether you're a very young child or an adolescent in terms of mental health access. Then of course, if kids losing their coverage makes that even more severe. There's no question. And the advocacy for the adequate coverage of mental health services needs to continue, but we also have this issue of kids who are going to lose coverage. In my state, we've done a significant amount of work around social emotional support around kids who are in the child welfare system, and have worked very hard with practices around identifying early, not waiting for a crisis for those kids in particular. And so this is a very unfortunate event in the sense that while we are having people have heightened awareness in identifying these things, we are now actually limiting their access to care.
Yeah. Thank you, Dr. Boyd and Dr. Earls. I want to hand the mic over to my PNHP colleague, Dr. Winnie Lin, who has a special message for us.
Hi, everyone. My name is Winnie Lynn, and I'm a pediatrician on the south side of Chicago. Thank you for joining us for this important discussion on what we can do right now to ensure that our patients never lose their health care. The COVID pandemic and now the state-by-state Medicaid unwinding demonstrate how far we have to go to realize that vision and why our system cannot be fixed with small tweaks. As soon as I began my career in primary care, I faced daily frustration about the systemic barriers to providing my patients with the care they needed. I knew I had to find a way to improve healthcare beyond what I could accomplish as an individual in my clinic, both for the sake of my patients and for my own sanity. PNHP has provided me with an advocacy home that has connected me with other doctors, including an amazing group of pediatricians who share the same vision of healthcare as a human right rather than as a profit-making machine. I hope that tonight's webinar convinces you of the importance of fighting for single payer as part of a strong and growing coalition and not just an individual frustrated physician. As a thank you for joining us tonight, we have a special offer. Use the link in the chat to become a PNHP member for just $50. You'll join thousands of like-minded colleagues who are fighting every day for the single-payer reform we all need. And if you're a pediatrician, don't forget to sign our petition to show your support for single-payer. The link is also in the chat. Thank you again for your time, and I hope you'll sign up to join our team.
Yeah, please definitely sign up to join our Rockstar Pediatrician team. We are mighty and growing here at PNHP and would love to have you. And for $50, like that's like an amazing deal. Like definitely join PNHP and our awesome pediatrician action team. I want to move on to our next segment with Dr. Rhea Boyd and Dr. Jane Oski. And you know, as we discussed earlier, many of the struggles our pediatric patients have endured, you know, the roots of those struggles predate the pandemic, and you know, and COVID-19 has not been the same, you know, across this country geographically or economically, and communities of color and families with lower income have suffered disproportionately from COVID. A lot of the families that are suffering, you know, these are the families of the essential workers that, you know, we hailed them as heroes, you know, just 3 years ago. And we've more essentially betrayed them now with this Medicaid unwinding. And, you know, I kind of want to dig deeper into that with, you know, with Dr. Oski and with Dr. Boyd, because it really doesn't come as a surprise to many of us that these are the same communities that are struggling now with this entire Medicaid unwinding process. So, you know, Dr. Oski, what do these injustices actually look like in your day-to-day work with the Indian Health Services? And how are our healthcare systems and inequities, like how are they manifesting themselves in the community you serve?
Thank you so much, Sanjeev, for that excellent question. I think for our audience to understand my response with regard to how the Indian Health Service is funded, it's important for them to know a little bit of the history. It wasn't until approximately 500 years after first contact occurred on this continent that there was an established Indian Health Service by the federal government. So in 1954, care and delivery of treaty-obligated health care to Indigenous peoples in this country was assumed by the Indian Health Service from the Department of the Interior. About 20 years after that, there was the Indian Self-Determination and Education Assistance Act, known as Title 38 to those of us who practice in the area. And that gave tribes the ability to provide their own care. At that time, about 50% of the IHS budget was given over to tribes to be able to provide their own care, and the other 50% continued to be provided through IHS federal facilities. In 1976, there was the Indian Healthcare Improvement Act, which was permanently reauthorized under the Affordable Care Act, and that strengthened the position of the IHS, as well as, for the first time, allowed funding of urban Indian programs, which is critical, because if you look at the people who identify as members of tribes across this country, about 50% live on tribal lands or on reservations, and the other 50% live in urban areas where they could not access care unless they had access to a dedicated Indian Health Service, tribal or urban clinic. The reason that's important is the funding on a per capita basis for members of tribes is 4 times less than the funding that is given to Medicare recipients. It's 3 times less than the funding for the VA. So 2 other basic single payer plans, and half of the funding that goes to typical Medicaid recipients. In order for members of recognized tribes to receive care at their facilities, they have to go to that site to receive quote unquote free care. It behooves those facilities to enroll those people, both children and adults, within the Medicare program, because then the tribal IHS and urban programs actually get a 100% reimbursement for those Medicare services. In the COVID pandemic, there were about an estimated, it's a large range, 30 to 80% reduction in third-party payments to tribal facilities because we just couldn't see outpatients. We couldn't see children, and children bring in, because we get to see them so often and there's so much preventive care, they bring in a lot of money to the facilities. The former chair or head of the IHS estimated it was going to take at least 5 years to recoup those monies that were lost. And since we're already at the bottom of the barrel in funding, the services that we can provide at all of the IHS tribal and urban facilities needs to be reduced. Then comes the unwinding. In Arizona, which was one of the first 5 states to begin their unwinding process with notices sent out in April, as of yesterday, 149 million people had had their Medicaid services or reimbursement services removed, and almost 80% of those were procedural. When you think about many of my patients who, some of whom live on the Navajo Nation, some of whom maintain addresses and mailboxes on the Navajo Nation, but work in Phoenix or in Flagstaff, they may go months before they check their mailboxes. They don't know what is waiting for them. And without a systemic approach to notifying all of these individuals, they will not likely get back onto Medicare or Medicaid services. Sorry for my lengthy reply.
No, I mean, that context is really helpful because, it really does spell out for us that this is, not a narrow problem, right? That it has roots in history and and I think a lack of intention with the way that we plan policy for healthcare, that emergency policies are just allowed to kind of just lift because people want to spike the football so badly on COVID-19 that they're not realizing how it's actually history repeating itself pretty mercilessly on communities that have been dealt this rotten hand again and again. And that kind of brings me to my question for Dr. Boyd about how do we take that history, this current moment, and kind of fit this current moment into the larger movement of building single payer? Because, what I really want to do is, make sure that we're prioritizing equity, that, racial justice is a very intentional process, and not just a fancy rhetoric that we do in this work for the long haul. So what from your vantage point, how does this, kind of fit together to where we need to be moving, Dr. Boyd?
Thanks. Yeah, Julia Kohler left a comment in the Q&A that I think kind of ties into this. She or they said, health insurance is being yanked away at the same time the child tax credit was taken away and SNAP was cut. She or they said, I feel like, as Sanjeev said, now that the essential workers, a large fraction of whom are Black/immigrants, are no longer seen as critical, they and their children are getting kicked to the curb. There's now a frightening degree of food and housing insecurity impacting children. You know, I think Julia has set it up. Like, I think it's important that we expand the scope of really what was propped up by the government during the COVID pandemic, which was the beginnings of what could be a true safety net for Americans economically, in terms of housing, in terms of food supports, in terms of healthcare supports, which we're talking about today. And now that that safety net is being literally ripped out from under people, the same forms of inequality that were already preying on communities are going to continue to render certain communities more vulnerable to death and disease. And that is predictable. It's what we're up against when we look at longstanding health inequities and health disparities for communities of color. And I think right now there is something just very dark about that happening right after we experienced, you know, the pandemic, right after we saw such an international display of why we need a really robust safety net. And so I think when you're thinking about what it means to have single payer, I think we're talking about more broadly what it means to have a very strong safety net, and what are the flagship programs that should be kind of the cornerstone of that safety net. There are folks who think that we should have kind of Medicare for all, and I'm not going to argue one way or another, but I think given our current focus on Medicaid, I do think there is an argument to be made that we should have Medicaid for all. Medicare is a really powerful program because the reimbursement rates are really powerful, but Medicaid is powerful because it covers the most vulnerable of us. Medicaid is already a program that enrolls people who are impoverished, right? It enrolls people children who don't earn any income, who have the highest rates of poverty of any age group in our country. It enrolls, right, people with special needs, kids who are in foster care. Like, it already is the program that serves those of us who are made most vulnerable. And we're thinking about who needs the safety net. Like, I think that is a very strong place to begin.
Yeah. I mean, one of the things about that vulnerability, which I was hoping that during the course of the pandemic that we would get more in touch with individually and collectively, is that, a lot of the illnesses that we deal with, whether they be COVID-19, cancer, asthma, I mean, a lot of these things don't do means testing before they strike you, like you're not people don't get cancer because cancer decide, oh, you can afford this. Epilepsy never decided that oh, you've got the finances to handle seizures. So now you're going to have seizures. It isn't like that. Our vulnerability is such a human part of our existence. And yet we've decided that we have to stratify, that we have to create all these complexities of worthy versus unworthy. And even with Medicaid, we make, enrollment and eligibility so complicated. And it feels like we haven't learned or unlearned anything from the pandemic in doing this work. And so I guess as we're looking to the future and we're trying to advocate against the worst of Medicaid unwinding, what do we want to have in its place? Because I think that's something that I would like us to advocate for, as much as we're advocating against the worst of Medicaid unwinding. If both of you could kind of share about what should we be advocating for in terms of values that ought to be there, because it seems like we don't articulate that enough, or if we assume the best in people, that we maybe need to actually make that more concrete. So Dr. Oski, if you wanted to kind of, take a crack at that.
That's an incredibly complicated question.
Yeah. This is why we bring brilliant people
if,
together, is to handle these complicated things.
If we looked at the services that were stipulated as required under the ACA, that would be a reasonable place to start in building what we would see as the ideal sort of foundational access to healthcare in this country. We would certainly in pediatrics want to have, on top of the standard preventive care, ability for all of our patients of need to be able to access specialty care. It shouldn't be something where a child, because of the color of their skin, gets bumped to the back of the line and may take 3 years to see a critical specialist, where one of their Caucasian colleagues, peers, could be seen within a month. In terms of mental health care, I think about in the community that I serve, on top of the fact that 1 out of every 134 Indigenous children in this country lost a primary caregiver in the course of the pandemic, and is being layered with the grief and historical trauma of the Indian boarding school program disaster that this country was responsible for. Those 2 things alone can heighten the need for mental health services. And then when you factor in poverty and family dysfunction and poorer schools and communities in disrepair and housing insecurity and food insecurity, every single one of our children should be able to have access to some form of mental health services. We know we don't have enough pediatric psychiatrists in this country to be able to provide that level of care or even medication management for children who may need it. But we have an abundance of qualified and talented therapists and psychologists who should be part and parcel of not just parity, but built into a program so that there is absolutely guaranteed coverage for those services.
Yeah,
I
Dr.
absolutely
Boyd.
agree with that. I think if I build off what Dr. Oski said, if we start with what the ACA offered, at least as a building block, maybe we could even expand that at some point to say, what would it mean to have healthcare include those kind of traditionally thought of healthcare things, plus vision, dental, and mental care, and then every form of caregiving? Why isn't the healthcare system like an umbrella for childcare? Why isn't it an umbrella for elder care? Why isn't it an umbrella for bereavement care? You know, like Dr. Oski said, like, we have seen communities of color grieve more, children of color grieve more as a result of the pandemic and pre-pandemic Indigenous and Black populations, because they have the highest mortality rate. Children and loved ones lose people more. These should be the cornerstones of the healthcare system, that we should support people working in roles as caregivers for each other, and that's a preventative effort. There is some work happening here in California to think about what it means to invite caregivers into the workforce that is paid for or reimbursed by our health insurance program, by Medicaid. Sometimes parents of kids with special needs, for example, can get funding from Medicaid to be, you know, the person who takes their child to healthcare appointments and et cetera. But that model could be expanded to think about all of the various caregiving roles that will be necessary, that the pandemic has made necessary, that inequality makes necessary in general, so that we can kind of be in community and caring for each other and not just receiving care, right, when we walk in the institutions that healthcare systems build.
And if we could somehow build a message to the general US public who uniformly support Medicare, how that message can be translated across the life spectrum. If people are supportive of Medicare, it is not socialism to expand that to from birth to the grave.
Right. I mean, because we've done expansions before that I don't think a lot of people appreciate about, you know, Medicare, is that, you know, there were, I mean, the program has been upgraded since 1960s, you know, Medicare. Like, that isn't the Medicare that our current, you know, patients are using right now who are in the program. And the idea that we have upgraded before, and this would, yes, you know, single payer would definitely be a big upgrade. It hasn't been that we haven't upgraded before. I do want to talk about one of the questions that came up in the Q&A box about an issue that's going on with in Florida with Governor Ron DeSantis. You know, one, not expanding Medicaid, but now requiring hospitals to document, you know, immigration status, to document the amount of uncompensated care going towards immigrants without documentation. And how is this directing resources that are not actually providing care? And how are we exacerbating inequalities for, for patients and families and communities that have done so much and meant so much to us, to our country? What is the danger of this type of policy, and how, and what are the threats that we need to be aware of before it spreads?
This takes me back, not so much with regard to immigration, but the risk to safety net hospitals takes me back to the 1980s and the AIDS crisis and the patient dumping that was going on. And that was a way for one hospital to basically save money at the expense of a human life. I honestly don't know what it will take for this country to embrace the concept of healthcare for all. It's, as we like to say in public health, inch by inch, it's a cinch, but we're barely moving millimeters. And we have had multiple administrations that have been enemies of expansion of Medicaid and even enhancements of Medicare. I don't know where to begin to address what I would see as step one, other than the ballot box.
I'll only add that I think it's important to just state flatly that those policies are xenophobic, they're racist, and they are structurally and physically violent. Like, they're meant to make people afraid. They're meant to make people afraid of seeking care. And that means that when people are afraid to seek preventative care, primary care, that by the time they do get a needed medical service, they'll be in some state of crisis, which obviously nobody's at their best, and their outcomes are worse when you have to seek care in that state. So the predictable result of that will be people will be harmed and hurt as a result. It's deeply frustrating and enraging to a degree to see what's happening in Florida happen. But I'll also say, I do think there's reason to have hope. Florida isn't the only state. Florida isn't the majority of states. And, for every Florida, there's a California, where if you're undocumented, you can get Medicaid. You can walk into any facility, and healthcare facilities here are sanctuary sites, where you can't be accosted by immigration control. So I think it's also important for us to highlight the areas where people are protected, where, we're not monsters, where we're not trying to hurt people anymore, where we're trying to care for people. And that exists. And hopefully folks who are able can come to the good states.
Thank you, Dr. Boyd and Dr. Oski. I want to hand the mic over to one of my friends on PNHP's pediatrician organizing team, Dr. Ndeng Izengja.
Thank you, Dr. Sriram, for leading such an important conversation tonight. My name is Ndeng Izengja, and I'm a primary care internist and pediatrician practicing in Boston, Massachusetts. We all know that access to quality health care is one of the most significant factors that ensure that children become healthy and stay healthy. With the unwinding of Medicaid, many families will be unceremoniously kicked off at what had previously been a stable and reliable health coverage. They'll be forced to choose between making rent or seeking medical care. Many will suffer health conditions that are manageable with proper and sustained treatment. I became a member of PNHP during medical school in 2015, and after recently attending their annual meeting in Boston, have since become an active member of their pediatric organizing team. I'm excited to share that we have a special membership offer for pediatricians and others who are not yet members of PNHP. If you donate $50 using the link in the chat, you will receive a 1-year membership. PNHP brings a depth to organizing that allows us to act collectively in ways that make a difference. I urge all pediatricians who have not yet signed on to our petition demonstrating wide support for single payer to do so by using the link in the chat. And don't forget to take advantage of our special membership offer, because when we organize, we win. Thank you.
All right. Thank you, Ndang, for your message. And thank you to Lori for adding the information about the photo petition in the chat, as well as the PNHP membership link. Please copy and paste that info and check that information out. It's super important to our work. And as we enter this last part of the webinar, I wanted to take a quick poll of all of you in the audience with the following question. What is the biggest barrier to your own single payer activism? Is it not enough time? Not convinced single payer is the right solution? Do you not understand the fine details of single payer? Not sure what activism should look like? Are you worried about how your activism will affect your work relationships? Which of these is the #1 single biggest barrier? Please tell us in the poll question box that just popped up. All right, so for this next segment, I wanted to really connect the Medicaid unwinding to the longer movement for single payer. So I'm really excited to have Dr. Oski join us back, and for Dr. Verhoef, president of PNHP, to be joining this conversation. And so I wanted to ask both of you, what difference would single payer have made in your work in the past 3 years, and how would it make a difference moving forward? Dr. Verhoef, Phil, for you, I wanted to ask you very specifically, what role do you see pediatricians having in the organizing for single payer? So Dr. Oski, I wanted you to kind of kick us off with what would single payer have meant in the past 3 years, and what would it mean moving forward for kids and families in the community you serve?
To begin with, if we'd had a robust single payer plan, then we may also have had a more robust national approach to the pandemic. A CDC that was respected, that was engaged with the government and helped in planning, that there was pre-planning, that there was a fully formed pandemic plan in place that from day one we could have activated to get supplies to every hospital and clinic that needed it, to be able to move critical healthcare providers that may not have been needed in one place to another without relying on volunteers, to basically have a healthcare kind of military model. I hesitate to use that, but that is exactly what the Commission Core of the Public Health Service was intended to be. And if we had had those structures in place through a single payer plan with every single child between the ages of birth and 20 or 26 years of age entitled to the same amount of services, then we would be able to have addressed and continue to address all of the horrific disparities that exist for children of color and for immigrant children. That would have been a dream. It would have also helped to ensure that the pediatric services at one site that may have been cut because of a dramatic increase in adult requirement for care would have been able to be provided someplace close to home. Our pediatric inpatient unit in Tuba City, Arizona, the westernmost town on the Navajo Nation, was completely shut down for the first 2 years of the pandemic. So any child that needed an inpatient hospitalization had to go to Phoenix. If you think about the impact that that has on a family, it's just indescribable.
And Phil, same
Yeah,
question to you.
I mean, I think it's a really good question. And I guess, we've talked a little bit already about all of the things that a stable Medicaid program would do for us, right? It would eliminate churn, which is the idea that you have to constantly re-enroll, that you're changing insurance all of the time. It eliminates things like prior authorizations or denials of care. That's one of the problems we have within the Medicaid program now. Medicaid programs also use often narrow networks or sort of draconian drug coverage policies. And so on the one hand, unwinding Medicaid is terrible. It's absolutely going to hurt people. It's going to hurt kids. It's going to hurt adults. But on the other hand, we could do so much better. And I think that's one of the reasons that I've been involved with PNHP, that, you know, I've seen how Medicaid works and how much it helps. I've seen how much Medicare helps, but I also know that there's so much more that we can do for that. And, you know, it's funny, I was thinking about what Dr. Boyd said, you know, maybe we need Medicaid for all. And there was a point made in the chat that the AAP is looking at supporting Medicaid becoming a federal only type of program. I think that would be amazing. One of the big problems with Medicaid is that each state's Medicaid program is different, and that leads to really wide disparities as well. So when I think about what a single payer plan would do, it eliminates all of these problems. And even in the current healthcare system we have now, under the pandemic, we still have 4 million children that are uninsured in this country. And that means that's 4 million children not getting ongoing well child care, right? They're not getting immunizations. They're not getting preventative care. They're not getting what they need ever. And so even though we have these good systems in place like Medicaid and CHIP and the IHS and what have you, it's not enough. And we can't settle, right? We can't settle for, well, this is the best we could do. We absolutely must demand that everybody get the coverage that they need. And you know, it's crazy, right? We recognize that kids are vulnerable. That's why we created the Medicaid program and the CHIP program in the first place. And yet we're still not serving them. We're still leaving kids behind. And now it's only going to get worse with this unwinding. It's just absolutely wild to me. We talk about how up to 65,000 people a year in this country die because they don't have health insurance. That is a staggering number. And we are complicit as a country in designing a safety net that's full of holes. And so, you know, a single payer system fills in so many of those holes. And that's really how I think about this and why this has been such an important conversation. Because, you know, everybody's been able to hear both the ways that Medicaid has been good, but also the problems that this is going to create. We deserve better for our patients, for our kids in this country, and I think that's really what we're driving towards here. I know that a lot of you have asked what we can do. Do we talk to our legislators? Do we write op-eds? We are building a toolkit for you. We are going to fire it out to everybody that participated in this. That will give you a bunch of different ideas that we've had for how you can get active in this fight. But I think the one other point I want to make with the last minute or two that we have is we're all pediatricians, and that means most of us are members of the AAP. We need to move this issue to the front of the AAP's legislative agenda, right? If the AAP cares about the health of children and there are still 4 million kids uninsured in this country, we are leaving behind so many kids. And so I think another place that we as pediatricians can work is to begin to work within the AAP. The AAP has a voice. Many of you participate in the AAP lobbying days in DC. Gosh, get involved in the AMA. The AMA is the 4th largest lobbying organization in DC. It has deep pockets. I haven't been a member for years, but I'm thinking about it because we need to tap into that power in order to make a difference. And I think that's one place that we can really make a difference in this fight. So Sanjeev, I'll turn it back to you.
Yeah, and I appreciate that answer, Phil, because, you know, as you know, you and I have both been seeing in the Q&A, there have been a lot of questions about, like, you know, voting just doesn't feel like enough. I've been doing that. And that really does open us to this next video from my SNAP colleague, Michael Massey, about our photo petition toolkit. And I'm going to hand it over to Michael to talk about that some more.
Everyone, my name is Michael Massey, and I'm a third-year medical student in Ohio, and I'm also on the national board for SNAP and PNHP. And I wanted to share a quick video with you on how you can help us in our organizing efforts and really join us in our advocacy efforts to get the American Academy of Pediatrics to support a single-payer Medicare for all system, a system that is truly universal, simple, and affordable. And many of you are actually already here because you've signed our petition online that has over 300 signatures from pediatricians across the country now. But what we really want to do is put faces to those names so then we can show the AAP or any other organization that we have a large community behind this effort and a lot of people supporting this. So the process is very simple. We just ask that you send a picture of yourself to our national organizer, Lori, holding one of these two signs. So if you are a student that is hoping to be a pediatrician, this one here just says, as a aspiring or future pediatrician, I support a single payer program. And if you are a current or retired pediatrician, there's one for you as well with the PNHP logo. And the process is very simple. You just put a neutral background behind yourself, take a vertical standing picture holding it, and then you send it to lori@pnhp.org. And then after this webinar, tomorrow we're going to be sending you a toolkit that has a bunch of advocacy resources for yourselves, so you can take it to your local chapter of the AAP, and there's a PowerPoint slide to help you in your discussion with those colleagues. And there's also tools on how to write an op-ed or anything else like that. So just be on the lookout for that tomorrow. And thank you so much for being on the call tonight, and looking forward to all the organizing we can do after this webinar.
All right, thank you, Michael, for that. And in these final seconds, I want to share the poll results from earlier this evening. And the question was, what is the biggest barrier to your own single payer activism? Overwhelming majority of you have said that time is really, kind of one of the biggest obstacles. And I think next up is not quite understanding the fine details of the policy. I think a few more were concerned what that activism would look like, and some are worried about how it will impact their work relationships. But I'm really glad to see that nobody is unconvinced about single payer being the right solution, because you're in the right team. This is what we're about. Okay, so as far as like the not having enough time, I'm hoping that Michael's video about doing a quick picture of you holding that sign is something that you can do and send to Lori, and then our team is going to compile a lot of those photos and we'll get that moving for you. So a few seconds of your time taking that picture actually will get amplified. And so if that's all the time that you've got, that actually is a big contribution for the movement. Again, go through that toolkit for those of you who are unsure what your activism will look like, and find something that's right for you. We're not trying to do a one-size-fits-all type of activism in the single payer movement and the fight against the Medicaid unwinding. Everybody's got to do something that is going to look a little bit different, but it's going to feel very personal and real for what's going on in your community. Once again, I want to thank Dr. Boyd, Dr. Earls, Dr. Oski, Dr. Verhoef for all of their insights and inspiration this evening. I want to thank all of you for joining us. Please check your email for more information about that exclusive PNHP membership offer. It's going to include that toolkit that Michael was describing. This video is going to be archived and shared with all of our PNHP members tomorrow. Thank you all so much for coming to this webinar. We look forward to you joining PNHP and the movement for single payer. Everyone in, nobody out. Thank you and good night.